Hello and welcome to this lecture called Extending the Fun. My name is Yasar Torres Yagi. I am the director of the Parkinsonism and Dementia Clinic, Georgetown University Hospital, also an assistant professor. I appreciate everyone working with us and listening today regarding this interesting and very informative and important topic. So whenever we think about Parkinson's disease care, we always have to think about the different types of medications that we have at our disposal. In 2021, so much has changed. If you see the timeline here, all the way since 1817, when Parkinson's disease was really first described by James Parkinson in the essay on shaking palsy, we see that there's been numerous breakthroughs, right? And so we're talking now close to 204 years of improvements and therapeutic interventions and exciting advancements and innovative ideas to take care of our Parkinson's patients. That's why a course like this is so important, understanding all the types of medications, all the different families that we have, not only provides hope, but also provides this sort of intellectually therapeutic capability that in the past, maybe in the previous generation of Parkinson's disease care, we didn't have. As we see since 1817, dopaminergic agents, there's been several advancements as we've also mentioned during this CME presentation. Levodopa, different formulations, dopamine agonists, the different types of drugs. So we're going to take a kind of rapid review. We're going to go 204 years in the making to be able to understand all the different therapeutics that we have now in 2021. And we're going to look at the clinical data that helped solidify and understand and vet the different therapeutic options. Don't forget COMT inhibitors, the COMT inhibitors. We're going to learn why they work. Monoamine oxidase B inhibitors, anticholinergics, amantadine formulations, A2A antagonists. So let's get started with this wonderful topic. And really what I want us to think about and how it is that we're going to use these medications sometimes as monotherapy, but oftentimes in combination with each other using a cocktail-like approach. Rational polypharmacy, similar to what we see in other fields, where we combine therapies from different families to provide ultimately a better outcome clinically. So here you see carbidopa, levodopa, and on extenders. Now we've seen this throughout the CME presentation, understanding how it is that these medications that we have can affect that off time, right? And so it's possible that when we use on extenders and we use adjunctive agents, we may have to also use as needed therapies. So we've dedicated a whole presentation based to that. But here you can see if we focus on the non-carbidopa levodopa medications, because we have a whole presentation based on carbidopa levodopa formulations. Here we can see the different types of medications and families. In terms of dopamine agonists, we have pramipexole extended release, ropinirole, rotigotine, which is a transdermal patch. We have rasagiline, selegiline, safinamide, selegiline and rasagiline and safinamide are monoamine oxidase B inhibitors. In terms of COMT inhibitors, we have entacapone, we have opicapone, and then we have what's categorized here as others, but in reality, amantadine in all its different formulations. We're going to learn about amantadine. In terms of immediate release, extended release, there are two formulations of extended release amantadine. And then istradefylline, a medication which is categorized as an A2A inhibitor. We're going to learn why it works and all the data surrounding that as well. So let's understand levodopa and the levodopa metabolism a little bit better. So levodopa is something that we utilize, as was mentioned earlier, to be able to be better clinicians. We have to utilize L-dopa, levodopa, and the goal is for it to enter the periphery of the blood after being absorbed by the gut or by other means, as we'll learn even more, but then cross from the blood into the brain, cross that blood-brain barrier so that it can then be converted into dopamine. And so we're going to utilize the different strategies to provide more efficacious and more augmented amounts of L-dopa to cross that blood-brain barrier. For example, rather than have L-dopa be broken down to dopamine, as you see in that picture, or the 3-O-methyl-dopa, we can use medications in combination with L-dopa. Cinemet or carbidopa levodopa in and of itself is a polypharmaceutical. So it's a combination therapy already. Carbidopa blocks the breakdown of L-dopa to dopamine in the periphery. COMT inhibitors, so something like entacapone, also blocks that breakdown in the periphery so that there's more L-dopa that crosses into the brain and provides that sort of metabolism within the brain after crossing the blood-brain barrier. Now, let's start our rapid review and understanding of all the different therapeutics, everything that we see here as on-extenders or adjunctive agents. Let's go way back to 1989, okay? So it's not as far back as 1817, but here you can see selegiline, based on this very important landmark trial. What we were able to show here as a scientific and clinical community was that we recognized that selegiline was an irreversible monoamine oxidase B inhibitor. And the idea was that it was clinically active by inhibiting dopamine metabolism in the brain, right? So by inhibiting monoamine oxidase activity. If we look back at the previous slide, within the brain, there is monoamine oxidase activity, which would break down dopamine into a metabolite. But when that happens in the brain, that metabolite isn't active like dopamine. So what we do with monoamine oxidase inhibition, monoamine oxidase B inhibition, selectively blocking B, what we see is that we see this augmentation of dopamine levels so that we don't have as much broken down into a metabolite, and then more can then be reused and recycled. And so selegiline in the past, since the 1980s, had been used as an agent that's given twice a day at 5 milligrams. Based on this clinical trial, what it showed was that the probability of reaching the endpoint was improved in patients that were on selegiline, and so in comparison to placebo. So what we looked at was the overall clinical benefit, and that we did see improvement in patients, at least clinically, patients that were taking selegiline. Of course, whenever we think about all of our medications, we have to think about side effects or adverse events. Insomnia, hallucinations, nausea, orthostatic hypotension are things that we think about. And you're going to hear that throughout this entire CME presentation. A lot of these concepts of how it is that we weigh the risks and benefits when presenting any therapeutic intervention. Now, when we think about the next study utilizing selegiline, remember, this other study published in 2004 actually looked at the utility of selegiline in combination with carbidopa levodopa. And so what we saw here, if you look at the graph, is the mean percentage off time on that y-axis. Over time, in weeks, at week 8, at week 10, at week 12, we continued to see significant reductions in daily off time. Remember, off time is that time where the medicine is not working and patients' Parkinson's symptoms return. And so what we saw with statistical significance, if you look at that p-value on that second bullet point, was that utilizing selegiline in combination with carbidopa levodopa, in fact, did lead to reduced off time. And the total number of off hours was reduced by 2.2 hours at week 12. And the average number of dyskinesia-free on hours, which is good on time, so that dyskinesia-free on time for the patients on selegiline increased by 1.8 hours at week 12, which was very helpful in understanding how it is that we're going to utilize medications adjunctively together. Now, let's dive in and look at all the important studies rasagiline has that we tend to think about every time we want to utilize a monoamine oxidase B inhibitor. Here you can see rasagiline is a second-generation selective, irreversible monoamine oxidase B inhibitor, high selectivity to monoamine oxidase B. Remember, non-selective monoamine oxidase inhibitors are the types that will also block A and B, and we may think about them as medications that we do not utilize in Parkinson's disease. Parkinson's disease, so we'll use the MAO-B inhibitors like rasagiline, selegiline, and we'll see safinamide next. But here we saw patients in this early tempo study that there were early Parkinson's disease patients. This was published in 2002, that were not requiring dopaminergic therapy at the time, but they were early patients. And what we saw here was that in the patients that were on 1 milligram, we also saw that there was an improvement in their UPDRS motor score. And let's look at, it takes about 8 weeks before we saw that optimal effect over time. Looking at that over a 26-week period, what we saw was that there was improvement in that UPDRS score in the 1 milligram group. and the 2 milligram group in comparison to placebo. Also, we saw this is a case where patients over time, from week 0 all the way through till the end of the study, we saw the progression of symptoms, that UPDRS motor score continue to progress over time in patients with Parkinson's disease on placebo. Let's now look to fast forward to 2005, looking at the PRESTO study. What we saw here was that Parkinson's disease patients, and there were 472 patients there, with at least 2.5 hours of daily off time, despite optimized treatment with other medications, including carbidopa, levodopa. We looked at their overall mean total daily off time in hours. And what we showed was patients that were on either 0.5 or 1 milligram of rasagiline showed improved mean total daily off time in comparison to placebo. And if you look at the actual numbers, what we showed here was that during the treatment period, the mean adjusted total daily off time decreased from baseline by 1.85 hours in patients treated with 1 milligrams and 1.41 hours in 0.5 milligrams. And remember, placebo, we did see a 0.9 hour improvement. Remember, the placebo effect does exist in many of our clinical trials. It's part of what we study. So the delta becomes very important, the delta between placebo and treatment group. So if we compared placebo patients treated with 1 milligram, there was about 0.94 hours less off time per day. Patients treated with 0.5 milligrams per day had about 0.49 improvement less off time in terms of the actual delta when it comes to treatment in comparison to placebo. Now, Largo study. So we see a theme here with these presentations in terms of studies. 2005 was published. What it was an 18-week randomized controlled trial looking at the evaluating rasagiline, its efficacy and safety in levodopa-treated patients. And what we looked at was the change from baseline in mean total daily off time. Here you can see patients that were on rasagiline and entacapone did see an improvement in that off time. And if you look, both rasagiline and entacapone reduced the mean daily off time by 1.18 hours in the rasagiline group, 1.2 hours in the entacapone group versus placebo, which was 0.4 hours. And there was statistical significance seen there as well. And then there was an increased daily on time without troublesome dyskinesias, about 0.85 hours versus placebo, 0.03 hours. And so we really kind of have to look at everything in its entirety, look at real world like studies utilizing multiple medications in combination. And what we see here is that if we look at the adverse effects overall, when we talk about rasagiline, of course, we're going to think about it within the context of medicines that have to do with dopamine augmentation almost, right? And so when we think, we always have to look for postural hypotension, syncope. When we think about the other things that can happen with all of our medications, things like constipation, nausea, vomiting, peripheral edema, these are the things that we look for. We might look for hallucinations, confusion, somnolence. Those are all things that we always look for in any medication that we might prescribe. Sulfonamide, now another monoamine oxidase B inhibitor. It's a reversible, makes it a little different than the previous two presented monoamine oxidase B inhibitors. It's given at 50 and 100 milligrams. And what we looked at here in presenting was a JAMA Neurology article published in 2017 that was very important and very informative. What we looked at here was over weeks of use, sulfonamide versus placebo, and we saw the mean change in on time. And so we would use sulfonamide in the setting of, based on this clinical trial, in the setting of carbidopa, levodopa, a regimen of that to treat off time and improve that quality on time. What quality on time means, remember, quality on time means the amount of on time without dyskinesia, and then also the amount of on time with non-troublesome dyskinesias. If you have troublesome dyskinesias, that puts us into another realm. So quality on time means that time where there's no troublesome dyskinesias, and where patients feel like their medications are working and they don't feel like their Parkinson's symptoms have returned. So what we see here is that either at the 50 or 100 milligram doses, we can utilize this therapy daily. And it was shown to improve on time by approximately about 55 minutes per day in the sulfonamide group versus placebo. Of course, now we're going to see also some kind of concepts being reinforced, but you see here somnolence, insomnia, Things like dizziness are things that we always talk about. Dyskinesias, of course, are something that we see. But if you see patients that are on all of our medications, these are things that we tend to talk about: nausea, headache. So think about these important themes, and remember that it might have to do with the medications that and the mechanism of action of all these medications that we utilize. Now, let's dive into the world of COMT inhibitors. So let's start with entacapone here. The mechanism of action is similar to a DOPA, decarboxylase inhibitor. And what we're seeing here is that it prevents the peripheral degradation by inhibiting COMT, right? Catechol-O-methyltransferase. And so we reduce potentially the levodopa dose necessary for a given clinical effect, potentially. And what we hope to achieve with the addition of entacapone, at least in the past when we used to utilize it based on the clinical studies, was it may have been helpful for patients that were having fluctuating Parkinson's disease, motor fluctuations, and may have been particularly useful for patients with Parkinson's disease that would experience off and on times and dyskinesias. And the idea is to extend duration of benefit, right? And so it was given at 200 milligram dosages. The Parkinson study group studied it in 1997 with the idea that it may have increased on time. And then again in 1998, again, maybe increasing that on time by 10%. And so that was the idea behind it. Now, when we think about side effects, of course, in this case, diarrhea, and then all of the other dopaminergic side effects that we've kind of touched on before. So when we call carbidopa, levodopa, and entacapone, and we've had a presentation on this, but understanding entacapone, its utility as a COMT inhibitor is very, very important. So what we might think about in terms of dosing, remember, we might think about utilizing 200 milligrams of entacapone in combination with carbidopa, levodopa, and maybe looking at that in terms of the clinical studies that have to do with improving the overall benefit after each dose in terms of duration of benefit. Here you can see the first step study, and what we were basically looking at was over time, the mean UPRS total score here. 423 patients with early PD were studied utilizing the doses seen here. And what we saw was that there was significantly greater improvement in the patients that were on carbidopa, levodopa plus entacapone in terms of their UPDRS Part 2 activities of daily living scores as well. And so this was an eye-opening study that was presented. Then when we think about the STRIDE PD study, what we're seeing is that in comparison to carbidopa, levodopa, the patients receiving carbidopa, levodopa, and entacapone had a shorter time to onset of dyskinesia based on this information and an increased frequency at week 134. And then time to wearing off and motor scores were not significantly different, but trended in favor of the carbidopa, levodopa, and entacapone treatment group. So initiating levodopa therapy with carbidopa, levodopa, and entacapone, based on this clinical study, there may have been some findings that may have been helpful, but utilizing entacapone earlier on may have been difficult in terms of delaying that time to onset or reduce the frequency of dyskinesia in comparison to just carbidopa, levodopa alone. So entacapone, when we think about adverse effects, we have to think about the numerous things that have to do with kind of dopamine augmentation, but also we have to think about the things that have to do with nausea, diarrhea, dizziness, constipation. If we look here, based on the clinical studies utilizing these therapies, it's helpful to understand them all together. Now here, opicapone is something that was based on the 2016 data of utilizing a once daily COMT inhibitor, something that became more readily available to us as clinicians. And what we see here is that the treatment with opicapone 5 milligrams or 25 milligrams was helpful in comparison, looking at that in comparison to, and 50 milligrams in comparison to placebo. So the treatment emergent adverse events were reported, and we're going to go over that as well. But the addition of opicapone 50 milligrams to levodopa treatment in patients with Parkinson's disease and end of dose motor fluctuations could have, based on the once a day dosing, the idea behind it was rather than have to give entacapone with each dose of carbidopa-levodopa, which was the case with the previous studies, this once-a-day dosing, logistically based on overall pill burden of patients that are already taking so many meds in Parkinson's disease, may have been helpful in simplifying drug regimens. So the most common adverse events were dyskinesia in 5 patients in the placebo group, 10 in the entacapone group, and 17 in the opicapone 5, 9 in opicapone 25, 18 in opicapone 50, insomnia, and constipation. So these are things that we, of course, look for. But what we're really showing you here is that the once-a-day dosing with opicapone, if you look at the bar graph, what we're showing you here is that 50 milligrams did show a mean change from baseline in terms of that improvement of off time with the 50 milligram group in comparison to the 25 and the 5, and in comparison to entacapone, 200 milligrams, all comparatively to placebo, which was helpful to understand the utility of a once-a-day COMT inhibitor, especially utilizing it just once a day in conjunction with your carbidopa-levodopa regimen. We discussed the opicapone adverse events, and this is just another way of taking a look at them. So dopamine agonists and distinguishing features. Remember, dopamine agonists carry their own clinical significance, but what we're showing you here is that what dopamine agonists do is they act like dopamine imposters, right? So it's almost like they directly stimulate the dopamine receptors. There is no metabolic conversion. It bypasses nigrostriatal neurons. No absorption delay from competition with dietary amino acids, which is helpful. As we know with carbidopa-levodopa, we may experience that. The dopamine agonists in general may have a longer half-life if utilized as extended release formulations. They can be utilized in monotherapy or adjunctives. And the idea behind them is that they can be utilized either alone, like we said, or remember, as our rational polypharmacy, that cocktail-like approach to care, which helps us a lot. Now, whenever we think about the different dopamine receptors, remember, if we think about the ones that we tend to utilize more readily, pramipexole is one that we tend to utilize more readily, ropinirole, apomorphine. What we're showing you here is that there are certain dopamine receptors that there might be more affinity based on different drugs. And so think about that also as part of the reasoning why we have these different therapies and why they might have different mechanisms of action in terms of all the different dopamine receptors that they modulate. Dopamine agonist pharmacokinetics and dosages, and I'd like to bring our attention to pramipexole. Says 8 hours, anywhere between 1 to 4.5 milligrams per day is utilized. Ropinirole, 4 hours when not using the extended release formulations of those medications. You can go between 3 to 24 milligrams per day. Apomorphine injectable, 1 to 10 milligrams per day. And then rotigotine actually is a 24-hour patch transdermal that is effectively being transmitted through the skin. And you utilize 4 to 8 milligrams therapeutically per day for a 24-hour patch. So common adverse effects, remember, nausea, vomiting, dizziness, postural hypotension, headache, dizziness, drowsiness, dyskinesias, of course, are things that we always think about. And then other things that have to do with potential mechanism of action of dopamine agonists. Now, rotigotine transdermal patch is something that's very helpful to understand. It's a 24-hour patch. It's very helpful, at least logistically. It's replaced every 24 hours. And it is considered more of a long-acting dopamine agonist that can be helpful in understanding. Now, anticholinergics, right? And so initially used as far back as the 1950s. And we understand that what happens in patients that might have a dopaminergic depletion, which is Parkinson's disease is a dopamine deficiency, we might see some cholinergic overactivity there. And effective mainly for tremor and rigidity when we think about anticholinergics and the data that go all the way back. Common agents are trihexyphenidyl, which we use more regularly. And then the other ones you see there are not used in more recent times. But side effects, imagine anticholinergic side effects, very different potentially than dopaminergic side effects. Dry mouth, sedation, confusion, hallucinations, constipation, urinary retention. Now, amantadine, when we think about its utility, it's an antiviral agent. This is a medication that's been reformulated since its inception. But let's look a little bit at the mechanism of action. Right now, the full mechanism of action may not be fully known, but we do know that it is utilized to help patients. Even though it was an antiviral, it was found to accidentally actually help Parkinson's patients. What we think it does is it enhances release of stored dopamine. It might inhibit presynaptic reuptake of catecholamines, dopamine receptor agonism, and NMDA receptor blockade. And so all of these things in combination may lead to its clinical benefit, but also whenever we think about mechanism of action, it might be also why we're seeing some of those adverse effects. So the dosing is anywhere between 200 to 300 milligrams per day. Immediate release amantadine is given 2 or 3 times a day. Amantadine extended release tablets can be given in the morning, and that can be helpful logistically and practically. And so what we see in terms of the ability to utilize these medications in all their different formulations is we think about similar side effects that we mentioned: autonomic changes, dry mouth, sedation, confusion, hallucinations, constipation, and urinary retention. Amantadine extended release in this long-acting formulation, if we look at this clinical study that was published in 2017, it was utilized as a therapy to see if there was actually an improvement of those levodopa-induced dyskinesias, right? That motor fluctuation sinusoidal curve that we think about in Parkinson's disease. And what we see here is that if you look at the primary endpoints, you compare placebo to treatment, there was, in fact, for dyskinesia, levodopa-induced dyskinesia, based on the pivotal studies, and you can see on the graph, there was an improvement of levodopa-induced dyskinesia, and there was actually an added benefit of improving off time as well, which I'm going to show you. And it's taken at night. And of course, side effects are very important to discuss, but hallucinations and lightheadedness are the main side effects that we discuss. Remember, mechanism of action helps us understand clinical benefit and then also side effects. So understanding all of these things is so important, especially in a very, very therapeutically driven advanced therapeutic course like this one. So I want us all to feel proud that we're getting through. This is a very heavy presentation, and it's very much based on data, and it kind of is the foundation of how it is that we use adjunctive agents. But here you can see amantadine extended release based on pivotal studies. What we're showing you here in these graphs is that was actually reduced off time in the patients that were on treatment by about 0.6 hours in comparison to placebo. And so what that means to me is not only are we seeing an improvement in levodopa-induced dyskinesias based on that dyskinesia rating scale, but we're also getting an added benefit of reduced off time. And so we do utilize amantadine extended release in this formulation as a tool in patients that have levodopa-induced dyskinesias and or wearing off. And so that's something that can be very, very helpful to have that kind of combination. Remember, other alternative medications may actually enhance dyskinesias. This medication can help reduce dyskinesias that are troublesome and improve off time. This is another formulation of amantadine extended release, mentioned a little bit earlier. This is some pharmacokinetic information. Essentially, what we're showing you here is that as the concentration over time enters the system, we can see that amantadine extended release in comparison to IR can be given once a day, which might be helpful just logistically when we're thinking about all the different therapies and all the different medications that we have in Parkinson's disease. Oftentimes our patients are on a cocktail of many different medications. So now here, a picture of the brain. Finally, we see a brain again. And what we see here is that we're actually looking at all these chemical or neurotransmitter centers, right? So if we think about medications, we always have to think about what neurotransmitters are being adjusted or changed, right? We know that Parkinson's disease is not only a disease that affects dopamine, right? We talk a lot about it being a dopamine deficiency. Remember, it also can be, we see serotonin dysregulation, we see acetylcholine dysregulation, we see neuroadrenaline dysregulation, we see GABAergic changes, histaminergic changes. So now I've kind of thrown out all the types of neurotransmitters or chemicals that we think about in the brain. But what about adenosine? Adenosine, the reason it's so important is because more recently what we've seen is that adenosine may be another important neurotransmitter that when modulated might help us. And let's understand that a little bit more. So remember, when we think about teaching in an academic center like ours, the direct and indirect pathway can be intimidating, but as a movement disorder specialist, the direct pathway and the indirect pathway are something that we really had to learn and conquer. And so when we think about direct and indirect pathways, I want us to know that the ultimate outflow of the direct pathway, when we think about the motor cortex down to the striatum, through the GPI and the thalamus and coming back up to the motor cortex, what we're seeing is that, in fact, the direct pathway helps us move, right? So it's something that helps us move. We think about that as our go pathway. And the indirect pathway is the ultimate outflow, the ultimate effect of that indirect pathway as we move down that right-sided schematic, essentially helps dampen or slow down movement. And imagine a gas and a brake pedal. So you got the gas pedal, you got the brake pedal. You might be driving I think a go-kart is what you would hit the gas and brake with at the same time. And what you see there is in our medications hope to hit the gas pedal to help our patients move and take our foot off the brake. And I'll tell you why it's important to understand that taking that foot off the brake, because what Parkinson's really is it's an underactivity of the direct pathway and an overactivity of the indirect pathway. So our patients are trying to move this go-kart, trying to move their body, but their foot's off the gas and their other foot's on the brake. So that leads to barriers. And so let's look at the gas and brake pedal again with this cartoon schematic so that hopefully we can kind of ingrain in our minds that go pathway is the direct pathway and the stop pathway is the indirect pathway. So we're going to see some concepts reinforced throughout this wonderful presentation CME course. I hope that kind of reinforcement helps solidify some of those things, ingrain those in our mind. But I want us to remember that green and red light and the gas pedal and the brake pedal. It's important because as of 2019 in the United States, based on pivotal studies performed in the United States and Japan, what we see here is that we now can utilize an A2A antagonist. So it's a non-dopaminergic medication called istradefylline, and it works on the indirect pathway. We know that in Parkinson's disease, we actually see this upregulation of A2A receptor activity in Parkinson's disease along the indirect pathway. So A2A antagonism or istradefylline can be used adjunctively based on pivotal studies with carbidopa-levodopa patients that are experiencing perhaps motor fluctuations. You can see here that you might see an improvement of off time and an improvement of good on time based on the 4 pivotal studies as we see here, which is kind of the idea behind why it is that we utilize these therapies. If you look at the bottom graph there, bar graph, look at study 3 and 4. And what we're showing you here is that you can utilize istradefylline at 20 or 40 milligram doses given once a day based on its half-life. It's a once-a-day medicine. And what we're showing you here is that there was an improvement of, if you look at the delta, anywhere between 0.65 hours to 0.92 hours in patients that were either on the 20 milligram or the 40 milligram group in terms of reduction of off time. Of course, when we think about adverse events, it's important to understand dyskinesias, right? Anything that we utilize, we always need to think about dyskinesias. In contrast to what I said about the amantadine medication, extended release medication that I showed the data there for. Here we see dyskinesias can occur in patients that are utilizing either the 20 or the 40 milligram group, 20, 40 milligram doses. Constipation is something we talk about, hallucinations, blood pressure fluctuations like orthostatic hypotension. Interestingly, looking at the data, actually, we saw the placebo group had 9.4 there in terms of falls, whereas we saw less falls in the Nurians 20 and 40 milligram group. Hallucinations is something that we see there in terms of adverse reactions. And then other things that are mentioned on that slide. Now, apomorphine, we're going to learn about apomorphine, its utility. Remember, this is a kind of going back to our dopamine agonist part of the presentation. We have subcutaneous apomorphine, and we're going to learn about that in our other lecture about on-demand and as-needed therapies. But essentially, we're talking about it here just to think about it in the context of the ways we utilize medications. Now, this is separate from the on extenders. This would be used as an as-needed therapy, but the compound nonetheless has been very helpful. There are different formulations of apomorphine. If you look at the apomorphine belt pump, it's widely available in Europe, but what we see here is that it's a subcutaneous a pump that is in clinical trials in the United States. So we will be learning more about that and how it might affect off time throughout the day as an infusion, subcutaneous infusion. Now, sublingual apomorphine, of course, is something that we think about, but it's usually within the context of as needed therapy. But I bring it in here because it is within the family of dopamine agonists. Now, why do we have motor fluctuations, right? And we're going to talk a lot about that as time goes on. But the reason we have motor fluctuations is because that therapeutic window continues to narrow, and that therapeutic window narrows over time as the condition progresses. Patients that are on more carbidopa, levodopa may experience actually more dyskinesias and wearing off. And so over time, as the condition progresses, a lot of the times beyond 4 years since Parkinson's disease diagnosis, we are always screening for those off periods and dyskinesias. Remember, as we go up higher on that sinusoidal curve, we might see more dyskinesias, and wearing off will lead to off periods. Remember, high protein meals may create a barrier. High protein meals will interfere with intestinal absorption of carbidopa, levodopa, will also interfere once it's in the bloodstream. That protein might interfere with the blood-brain barrier penetration of our medications. And then so we have to think about off periods and how to treat them. That's one of the beauties about using once-a-day medications or adjunctive medications to help extend that on time and reduce that off time, is that we use these medications in combination to try and reduce off periods and smooth out those peaks and reduce the troublesome dyskinesias. That's kind of what we do. Now, the reason we're talking about them now is because we're kind of entering now to a brief conversation, which we'll expand on in the future, about surgical treatment modalities. As we see here in terms of surgical options, we see that deep brain stimulation, of course, is something that we utilize to try and help our patients that are starting to experience or in those more moderate to advanced stages of motor fluctuations, where our oral therapies may not be giving them the benefit that we had hoped or that we had seen previously at the beginning of the condition. So we utilize surgical treatment modalities in combination with our oral therapies, bypassing the gut dysfunction that we know about, that we know happens in Parkinson's disease, that decreased gastric emptying that leads to the variability of absorption of our medicine, the loss of those neurons. So we lose that storage or buffering capacity. And so we fall prey to the up and down of dyskinesias and wearing off. So ways to stabilize our patients can be found in these surgical treatment modalities. Surgery for deep brain stimulation in either the subthalamic nucleus or the globus pallidus internus. Apomorphine subcutaneous pumps, as we are studying them in the United States now only in clinical trials. We have a medication that we've discussed already, but which goes through a medication infusion port or PEG-J pump that goes into the jejunum of continuous carbidopa, levodopa intestinal gel, which this is another concept being reinforced. But essentially the idea of DBS now is to think about it as electrical stimulation. It's FDA approved for Parkinson's disease therapeutic surgical modality, and it's a high frequency pulsatile type of stimulation. And the idea of it is that it kind of leads to this a modulation of our circuitry in our brain, right? And so the idea is to target the subthalamic nucleus or the globus pallidus interna in Parkinson's disease. And if you look at the Parkinson's disease study groups, clinical study, evaluating patients with DBS, essentially, if utilizing DBS was helpful, and the results showed that stimulation and medications act together, right? So we use our oral therapies, we use stimulation as another way of introducing, actually, it's kind of like a rational polypharmacy. It's a way to stimulate the brain and get clinical benefits as we hoped we would get with oral therapies. And what it showed based on all the different studies utilizing deep brain stimulation is that it improved tremors, rigidity, bradykinesia, gait, activities of daily living. So there's a lot of clinical efficacy data there. So let's look here at this kind of landmark New England Journal of Medicine clinical trial that looked at ADLs, activities of daily living in our patients, and the different components of Parkinson's disease in terms of tremor, rigidity, akinesia, speech, postural stability, what we saw was marked improvements in motor function by about 54% in patients that were not even on therapy in the off state. So when they're in an off state, we actually saw that improvement of motor functionality there, 54% of patients. Activity of daily living saw a 49% improvement. Dyskinesias while on medication actually were reduced by 58%. And the duration of benefit from the medicine and the duration of dyskinesia time actually was reduced by 71%. Now, we have to kind of understand this was we were looking at a group, not in comparison to placebo, based on this New England Journal of Medicine article. But what we're showing you here is that the ADLs also improved in patients after surgery, even off medicine. So these are patients that actually did better when they were in an off state, which was very, very helpful. The impact of DBS on quality of life, as we see here, what we're showing you is that neurostimulation was helpful. And we see all aspects here: mobility, activities of daily living, emotional well-being, body discomfort, cognition, communication, in comparison to the red and medications. We saw improvement. So stimulation, electrical stimulation of the brain, based on this wonderful kind of landmark study looking at quality of life, published in the New England Journal of Medicine, was very helpful. Now we're nearing the end of this presentation, but what we're showing you here is that DBS devices are so have also advanced, and that gives us hope and positivity. We see all the different types of interfaces, user interfaces from the different types of DBS. We have DBS that can stimulate at 8 contact points. We have DBS that can now sense brain activity potentially. We have remote programming. So there's a utility for each different type of DBS that can be administered. Now, we always have to make the decision about whether we should implant in the subthalamic nucleus or the globus pallidus. But we know is that we can see an improvement of off-time UPDRS motor scores by 60% in the treatment arms that patients that were stimulated with DBS. On-time also improved, that quality on-time also improved, reduction of dyskinesia, and the total levodopa dose, if DBS was implanted in the subthalamic nucleus based on data, actually reduced from, on average, close to 1,200 milligrams to about 760 milligrams. So we could actually reduce the total amount of carbidopa levodopa needed. So the subthalamic nucleus is one location, but remember the globus pallidus internus is another location we might utilize. Remember, even though DBS is a neurosurgical procedure, it can be turned off, right? And it doesn't destroy normal brain tissue. It's adjustable. We can adjust as we see our patients. That's part of a movement disorder specialist training, that 34 years, including preschool of training, that allow us to be able to kind of fine tune things. Now we know it's not a cure for Parkinson's disease, and it doesn't take the place of medicine, but we see a lot of convincing and compelling data there that we can see a lot of benefit. So remember, DBS is something that we utilize. Now we're going to learn more and more about its application for other conditions, but right now we can use it for Parkinson's disease, essential tremor, dystonia in our Parkinson's world. And so we have, in conclusion, we have a lot of things, multiple medications that can help improve quality of life of individuals with Parkinson's disease. The concept of rational polypharmacy is not uncommon. It's part of our training is how to utilize medications in combination to provide that stability. Get our patients maybe off of that roller coaster ride that we've talked about. Advanced therapeutics courses like this that really focus on data and understanding medication administration can be helpful. Every patient is different, so we have to always individualize our treatment plan based on what we know of a patient. You know, how predisposed are our patients to have orthostatic hypotension or hallucinations? Are we screening for those things? We're going to learn more about that as well, screening for some of the non-motor symptoms of Parkinson's disease. And then the team effort approach between patient and physician. This is a field that requires a big team. And that's why advanced care providers, nurse practitioners, physician assistants, general neurologists, gastroenterologists, I mean, you name it, physical therapists, speech therapists, social workers, all of these people become very, very important in our treatment plan. And so thank you very much. I very much appreciate you listening to me through this. You saw how fast I was talking, this rapid review This in and of itself can be expanded, and we can talk a lot more about this. But hopefully in this rapid context, we touched on a lot of points that were helpful for advanced therapeutics in 2021 for Parkinson's disease care. Have a wonderful day.